All right, so we are recording here. I'd like to introduce Ms. Tiffanie Kemp, who will be presenting this evening on gynecological emergencies. Give me one sec, Tiffanie. Make presenter. Yeah, right. Okay. All right, Tiffanie, you are the presenter, so I'm going to shut off my camera so you could just go ahead and hit screen.
I think it's working on it. It just wants to make sure that I'm okay. Okay. All right. Now, can you see the screen? I'm trying to get rid of some of the other junk here. Hang on.
Yes, we can see it now. You'll just have to increase the screen size. There you go.
There you go.
And just put it in presenter mode and you're good to go.
Yep. Working on that here too.
All right.
Well, see, we use Blackboard and it's already set up for me. So anyway.
Unfortunately, Blackboard Collaborate is very difficult to utilize on our end, so that's why we're using this.
That's okay. I've used that and Zoom, so I'll just add something else. So
all right.
It's all good.
It's all yours, ma'am. And after Ms. Tiffanie is done, we will be done for the evening. So if anybody has any questions, please raise your hand. Please feel free to ask any questions. There's the chat room if you have any discussions going on, or she runs the show. It's her classroom. And thank you again, Tiffanie.
So good evening. I'm very informal. So let me just start with that. Secondly, the way I got here is that my son graduated from this program last August, and he is currently working as a paramedic. And my second son was in that program last year and had to take a leave for his last semester because he got into the fire academy. So hopefully, if all goes well with you guys as well, he'll come back and join you guys for the third semester, and then he'll be graduating in August with you guys, hopefully. As Rick said, I am actually a women's health nurse practitioner. I was an OB nurse for 14 years prior to becoming that, and I've been a women's health nurse practitioner for 7 years in June this year, and I graduated from Drexel, and I still teach for them as well. So we do a lot of online things. So we're going to talk about gynecology. It's, as I said, going to be very informal, and if you guys have any questions, holler out or whatnot, because I'm not real familiar with all the different little things that are going on here. So I'll just get started so we can get you guys done and get out of here. So gynecology is not coming up the way I wanted to. Oh, our objectives for tonight are we're going to talk about the anatomy and physiology of the female reproductive system. We'll talk a bit about the menstrual cycle, assessing a GYN patient, management of some GYN emergencies, and then some specific GYN emergencies. So gynecology comes from the Greek word meaning woman, and it deals with the health maintenance and diseases of women and their reproductive organs. Most of the anatomy is either external or internal. The external genitalia, the overall broad term, is the vulva, and then of course there's the internal genitalia. The picture of the external genitalia there, so you can kind of see, but mostly we have the perineum. That's the muscular tissue that separates the vagina, or the vestibule, the opening to the vagina there, and the anus. The mons pubis is that fatty layer of tissue over the pubic symphysis. You have the labia majora and the minora. Those are the structures that protect the vagina and the urethra. The clitoris is the vascular erectile tissue that lies anteriorly to the labia minora, and then the urethra, which drains the urinary bladder. Here's a picture of the internal genitalia. And then also we have the vagina. That's the female organ of copulation, the birth canal, the outlet for menstruation, the uterus, which is obviously where the site of fetal development, the fallopian tubes, which transport the egg from the ovary to the uterus. Fertilization usually occurs in the tubes, and then the ovaries, which are the primary female gonads. And then just another picture of all of those pieces and parts, looking at it from another different angle. You can also see the ligaments that attach the uterus to the sidewall, the round ligament, the broad ligament. Sometimes, especially in obstetrics, you'll get patients that have a lot of pain in those types of things, and they come by ambulance. So a quick little overview of the menstrual cycle. Obviously, it is the monthly hormonal cycle. Usually it's 28 days, prepares the uterus to receive the fertilized egg. The onset of menses, known as menarche, usually occurs between the ages of 10 and 14. However, it can occur before or after that. If it hasn't occurred by the age of 16, then they look into other things to be sure there are no other problems that they, Müllerian anomalies and things like that. So there are distinct phases of the menstrual cycle, and with each distinct phase, it's dominated by a certain hormone. There's an entire axis that takes care of all of this, that helps the feedback and stops the different hormones at different times. You have the proliferative phase, the secretory phase, the ischemic phase, and the menstrual phase. This is just a nice little picture. It kind of tells you what's going on at different times, and it has the cycle there in the middle. It tells you what hormones are dominating which different phase, and depending upon whether they are more hypothalamus, pituitary, or ovarian type hormones, and then what is occurring to the endometrium and also the follicles during that time. And just another kind of smaller, easier way to look at it. So the proliferative phase is typically the first 2 weeks of the menstrual cycle. It's very estrogen dominant. The estrogen causes the uterine lining to thicken, to engorge with blood. When all of this happens, that's when you know, the estrogen is at its highest, and ovulation will typically take place around day 14, which is when there's a surge of the luteinizing hormone. In the ovaries, there are lots of immature follicles called Graafian follicles, and you are born with all of the Graafian follicles that you will have your entire life if you're a female, and they're gradually used up during your lifetime. The follicles reach maturity due to the FSH being released, and that also increases the estrogen. As the follicle starts to rupture, it discharges the egg through the ovary when that LH surge takes place. The ruptured follicle then turns into kind of a body of cells that is the corpus luteum. Typically that goes away on its own, it atrophies, shrivels up, and goes away, but sometimes it does not, and it can get fluid filled or blood filled, and women can have problems with ovarian cysts related to that. If the corpus, or if the egg is fertilized, the corpus luteum will then start to produce some progesterone until the placenta starts to take over later on during the process. So the egg is released. If it's not fertilized, menstruation will take place. If it is fertilized, as we said about the corpus luteum, there's little fimbriae that kind of sweep back and forth that sweep the egg toward the uterus, and then it goes down through the tube and into the uterus, where it will implant later. If it's not fertilized, obviously it'll be expelled from the uterine cavity. So the secretory phase is usually referred to as ovulation, and that's when the progesterone will start to increase and the estrogen will drop if the egg is not fertilized. If the egg is fertilized, the estrogen will kind of stay kind of steady, and the progesterone will continue to increase. That will stabilize that endometrium in there and allow for it to be very vascular for that egg to implant. You then get to the ischemic phase, where estrogen and progesterone kind of level out without the fertilization of the egg. They become a little bit more equal. The vascular changes cause the endometrium to turn pale and blood vessels start to rupture in there. And that goes into the menstrual phase, where the ischemic endometrium is shed with blood, mucus cells, and that is your menstruation. It typically lasts 3 to 5 days. It's usually about a 50 cc blood loss, and the absence of menstruation in any woman of childbearing age and sexual activity, you should suspect pregnancy until it's ruled out otherwise. So just some of the things that can go along with premenstrual syndrome. There is marked physical signs and symptoms prior to the onset of menses, and they can be physical or emotional. We have menopause, which is the absence of menses for 12 consecutive months, and the average age in the US is 51 to 52 years old. And premenstrual dysphoric disorder, which is similar to PMS, but it's severe depression, irritability, tension before menstruation, and it's typically 5 to 11 days before the menses, and it typically stops shortly after the menses begins. Any questions thus far? I know this is a lot of stuff that you're probably all not really too worried about. You want to know how to assess them and keep on going. So assessing the gynecologic patient. So the most common complaints are abdominal pain and vaginal bleeding. Those are the typical two main complaints of women, whether they're calling for ambulance, coming to the doctor's office, things like that. So dysmenorrhea is severe discomfort during the menses, and dyspareunia is painful sexual intercourse. So you have your primary and secondary assessment, and those are specific to reproductive function and dysfunction. So you're going to want to kind of remember those things as you go through. Quite comically, I had to ask my sons last night what the OPQRST and sample, because that's not something that we typically use in the office. So I did get a nice education on that last night. So when you're looking at your history for your patient, you're going to want to make sure that you have asked them, you know, their signs and symptoms, their allergies, their medications, their past medical history, you know, when was their last period, have they eaten anything, have they not eaten anything, you know, did anything happen that led up to this pain that they're having or this bleeding that they've started to have. And then you're going to want to delve into the concern more. Did anything make it worse? Does it go anywhere else? The quality, the radiation, the severity, the time, and then of course the rating of the pain. You also want to ask, do you typically have, you know, the dysmenorrhea? Do you have pain with intercourse? Anything that associates to those signs or symptoms that they have. You want to ask their obstetric history, their gravida and their para. So gravida is how many times they have been pregnant. Para is typically spelled out in several numbers, but most people just write the amount of living or live births that they have. But you're going to want to know, have you ever had an abortion? Did you have surgery to have that? Have you had any belly surgeries? As we said, document their last menstrual period, their sexual activity, any type of medications they're on. They can all affect those menses and painful periods, heavy periods. You know, do they have a thyroid disorder? People whose thyroids are out of whack can have significantly heavy bleeding until they get their thyroid under control, or the exact opposite. They have absolutely no bleeding because their thyroid is so out of control, and that all affects that HPO axis that's in the brain. So a little overview of the different types of contraceptives. Obviously, you know, you have the rhythm method, withdrawal, condoms, diaphragms, which aren't used quite as much as they used to be, spermicide, IUDs, and there's so many different kinds of IUDs. You have essentially the Paragard, which is the copper IUD, and then many, many different kinds of progesterone only that can last anywhere from 3 to 5 years. You have birth control pills. You do have the combined estrogen and progesterone birth control pills, but there's also progesterone only birth control pills, and they can lead to some breakthrough bleeding and just some irregular bleeding and different things like that. I see on these slides you have Norplant listed. It's not typically used quite as much anymore now. Those were those old little match sticks. There was like 5 of them that used to get implanted, and then they would have to get surgically removed, and they stayed in for several years. The bigger thing now is the Nexplanon, which is a little tiny rod-like. You feel it, it's maybe 1.5 inches long. It's pliable. It's usually in the upper outer part of the arm. And that can, you know, does progesterone only and is a very good effective birth control that is long lasting and women don't have to worry about. You have Depo-Provera, which is the shot that's every 3 months. And then, of course, you can have a tubal ligation, which is effective, but it requires surgery. But that does increase your risk of tubal pregnancies if you've had a tubal ligation. And then, of course, they don't really have it listed on here, but vasectomy is obviously also a form of contraception. And when women say, I don't need this, my husband had a vasectomy, and they're still of childbearing age and they don't have a period, you should still rule out pregnancy, because unless they went back, they may not have finished their checkups for that, and women can still be pregnant. So if you need to do a physical exam in these times, should obviously respect the patient's privacy. I'm sure you're always going to be professional. Explain what you're doing, and always have a chaperone. Even as a female, they recommend that we have a chaperone when we do any type of exams in the office, or clearly document that the patient declined that. Observe the patient, see what they're saying, see what they're doing. The patients that tell you their pain is a 10, but they're chatting on their phone, all of those types of things. Check their vital signs, assess for bleeding or discharge. Don't and shouldn't ever do an internal vaginal exam when you're not in a hospital. You should not do them out in the field if you do not have to. And when you do an abdominal exam, you should palpate and auscultate, or auscultate and palpate, because you should always listen before you start pushing around, because that can increase A, their pain, and B, bowel sounds and things like that. So you'll want to check on or talk to them, their mental status, how's their skin color look, blood pressure, pulse. Do they have any orthostatic changes when they're telling you they're, soaking a pad in an hour and it's a heavy pad? Is there any evidence of bleeding that you see? How many pads have they used? Have they soaked it in the last hour? Is it a panty liner? Is it a big pad? And have they had any clots? And if so, what's the size of those clots? Are they large? Are they small? Do an experiment sometimes, and you can see 10 cc's of water versus 100 cc's and how it looks on different pads and things. They are definitely different to tell. And a lot of times when we talk about clots, we'll talk about the size of the clot. That way everybody's on the same page. It was a nickel, it was a quarter, it was a 50-cent piece, it was the size of a grapefruit, whatever that case may be. And document the color. Was it brown, which is typically older blood? Was it red? Was it bright red? What was that like? Management of those gynecologic emergencies, and generally there's not a lot you're going to do. So you're going to focus on the supportive parts, oxygen. If they've lost a lot of blood, do they need an EKG? Do they need an IV started? Do they need some pain medication? Those things that you can provide. Don't pack anything in the vagina. If you need to put a pad on, you can put a pad on, but don't pack anything in there. Positioning for patients is that left lateral laying back, sometimes the knees bent. It helps to take the tension off of the peritoneum, and then they have less pain in their belly. And then transport and psychological support. So then you have your gynecologic medical emergencies and trauma. They tell me that these are the most important ones for you guys to know about and learn. So we have pelvic inflammatory disease, and I didn't spell all this out on the slides. It can be caused by a bacteria, virus, or a fungus. It's one of the most common causes of non-traumatic belly pain. It's typically caused by gonorrhea or chlamydia, and it's usually diffuse abdominal pain. They really can't tell you where. They kind of do that hunched over, shuffling walk. They'll have fevers, chills. Some have nausea and vomiting. Some have bleeding, vaginal discharge. You're going to treat those patients with mostly the ABCs, making sure everything is okay, supportive care, comfort, transporting them, and when they get to the hospital, obviously they'll get antibiotics. I do have some pictures here. So you can see the inflamed ovary, the inflamed fallopian tube, and if you remember that other picture that I showed you, all those ligaments that attaches to the side. So depending upon which side it's on, they'll have more pain on one side or the other. If you palpate their belly and the top of their uterus in any way, shape through the belly, their fundus is usually extremely tender because everything is infected. Then we have the ovarian cysts. As I said before, sometimes the follicle, once it releases, that disintegrates, and sometimes it ends up sitting there and they'll end up with fluid-filled cysts or even blood-filled cysts that can rupture and spill the blood or fluid into the abdomen. It's usually the blood-filled hemorrhagic ones which cause more problems. Signs and symptoms of that can include the moderate to severe unilateral abdominal pain, so one-sided or the other. Pain may radiate into your back. They'll have painful intercourse, irregular bleeding, their period's a little late, they spotted a whole lot, but nothing was real consistent. And the same type of treatment that you would for the pelvic inflammatory disease. It's the ABC supportive care, comfort, transport, and depending upon the cysts and what was in it and the amount that was in it, they can also do surgical options. The other thing that they get concerned about is an ovarian torsion. If somebody gets a large cyst on their ovary and it twists that tube, the tube in the ovary, it will form a torsion, and then the blood flow to that ovary is cut off and it can become necrotic, and obviously it's very painful and it is an emergency and they do need to have surgery to have that fixed. It usually involves removing the ovary. So the next is cystitis, which is urinary bladder infection. Most common cause of abdominal pain, it says. However, I deal with these every day with patients because of the specialty that I'm in now, and usually they complain more of pain when they pee as opposed to abdominal pain, but it can include abdominal pain, frequency, burning when they urinate, real low-grade fever. Some people will see blood in their urine. They can't empty, they're in the bathroom all the time. And that would be ABC, supportive care, comfort, transport, and antibiotics. And I honestly can't believe that people would call the ambulance for a bladder infection. But anyway, Mittelschmerz, which is mid-cycle abdominal pain at ovulation. Some women will get a lot more pain than others. Some will say, oh, I know that I ovulated from a certain side, but it can be significant pain where the peritoneum becomes irritated when that follicle ruptures. They'll have pain on one side or the other, that lower quadrant. They may have some spotting. Some women will get a low-grade fever. Although their body temperature does normally increase at ovulation, they think it's significantly more than that normal, and they just essentially will get supportive care, comfort, and you'll take them to the hospital. And then there's also endometritis, so that's the infection of the uterine lining. Occasionally this can be a complication from a miscarriage, it can be from childbirth, dilation and curettage, or even a DNE for something afterwards. You know, they had some postmenopausal bleeding and they had a DNE. They can get an infection in the lining of the uterus. This is can be just like pelvic inflammatory disease, where they have those same signs and symptoms, but let's say they're not sexually active, but they've had recent surgery or a recent miscarriage. So that goes back to why that history is extremely important. Complications of the endometritis can be sterility, sepsis, and death. So it is extremely important to get that good medical history. The signs and symptoms can be that lower abdominal pain. They can have a bloody, foul-smelling discharge or other. They can have a fever. It's usually within 2 to 3 days or 48 to 72 hours after that procedure, that miscarriage, that you'll see that this can happen. Women can have this after childbirth, especially on a manual placenta removal, or they had to go in and help the placenta come out a little bit. Those types of, even if it was with a curette, those women can get the endometritis. They labored for a really long time with their water broken, and that's the typical presentation of that. And it can be serious if it's not treated right away. So make sure that you just look for those things and ask those right important questions. And then there's a picture somewhat of an ectopic pregnancy. So instead of the fertilized egg implanting into the uterus, it implants into the tube. And as it starts to grow, the tube obviously can't grow with it. And as it gets quite large, women will get significant pain on that side. And they can also have a little spotting, so they think they're getting their period and this is just painful. However, that can rupture and they can obviously then bleed into the abdominal cavity. They'll have that pain on the one side. Sometimes it'll radiate to their shoulder of the side that it is. They'll say, you know, I'm having some bleeding, but my period is late and this isn't like my normal period. So just one other thing to think about, because that also is a pretty significant emergency. As we said, make the patient comfortable and transport is the thing. So vaginal bleeding, just to cover kind of the two main things that we talked about, which would be the vaginal bleeding and the pain. So the non-traumatic things you may see are the menorrhagia, or just painful periods. Spontaneous abortion, they may or may not have even known they're pregnant. They're just a couple days late, and that's where the bleeding is from. And then fibroids, which are kind of little, I hate to use the word tumors, but that's what they use, that can grow in the uterine muscle, on the side of the uterine muscle, or even in the cavity in and of itself. And they can be painful, especially as the uterus stretches or cramps during pregnancy, or even before pregnancy, just as a regular GYN when they're getting ready for their period and they start having cramps, they can become very painful. Again, for the vaginal bleeding, don't pack the vagina, but you can put something to absorb the blood flow, transport them, initiate their oxygen and IV access based on the condition that you feel that they're in. Traumatic gynecologic emergencies. So some causes of gynecologic trauma. You have blunt trauma, and then obviously sexual assault. Blunt force to the lower abdomen, foreign bodies that can be inserted into the vagina, and then of course there's abortion attempts that could have been done on their own or by others because they couldn't go have one. So managing the gynecologic trauma, you would apply pressure over the laceration so that it's not continuing to bleed, but again, not packing, just over that. A cold pack can sometimes help with that as well. The IV they would need if it's a severe trauma or significant laceration, something along those lines, and then getting them transported. And the things that would go along with that if they have a large laceration and they're bleeding and they need oxygen or things like that. So sexual assault, obviously that's a very violent crime and it happens often in the US. And typically, you know, if you get called for one of those, it's not someone that's able to walk into the hospital on their own. So you don't want to ask specific details of the assault. Now, if they tell you those things, you're going to want to document them appropriately, but you don't ever ask the specific details of the assault. Don't examine the external genitalia unless there is a life-threatening hemorrhage, because you want to try and preserve all the evidence that you can preserve. You want to protect the scene. You want to handle their clothing as little as possible. If you have to have them take off something, a jacket because they had 2 or 3 on or something along that sort, you want to make sure that it's bagged, each item in its own little bag. Don't cut any clothing off or poke any holes through it, so that is also preserved. Any bloody articles put in a brown paper bag. Try not to examine the perineal area, as we already said. Don't allow the patient to change their clothes, to bathe, to douche. Don't wipe blood off their hands. Don't let them comb their hair, brush their teeth, clean their fingernails, and try not to clean any of their wounds if that's possible, to preserve any type of evidence that they have. So when you're documenting for a sexual assault type victim, you're going to want to state everything accurately that the patient has told you. So if they do tell you different things about the assault, you're documenting them accurately. Objectively state your observations of the patient's physical condition, the environment, torn clothing, those types of things. Try not to give your opinion, just objectively what their condition and such was. Document that you turn the evidence over to the hospital staff. And again, do not include your opinions as to whether a rape or not has occurred. So, summary of the GYN portions there, majority will have abdominal pain and vaginal bleeding. They may be uncomfortable for the patient. Detailed history is very, very beneficial, and the best historian is the patient. There's very little that paramedics can do for these GYN emergencies except the routine care and try to treat them symptomatically. Does anybody have any questions right now? I know that there was a case study, a you make the call thing, and then there's some review questions if you want to go over those to be sure that you know what's going on.
Tiffanie, it's Rick.
Uh-huh.
Would you be able to explain a little bit more regarding the definition of gravida, para, and aborts when it comes to the shorthand nature of when they do a gynecological history? What a little bit more in depth on what the gravida para means?
Sure. So gravida is the amount of times a woman has been pregnant, regardless of outcome. So if they've been pregnant 7 times, they're a gravidus 7. It's essentially the amount of times that they have been pregnant overall. Doesn't matter how it ended. And then as where I work, the para is typically listed out in 4 numbers. It's TPAL. So the amount of term pregnancies they've had would be the first number. The amount of preterm pregnancies they've had, so that's any pregnancy prior to 37 weeks that they have delivered. Then you have abortions, and then you also have living. Now, abortions is the biggest classification, I guess I'll say, because there's many different types of abortions in the medical term world. You have elective, obviously, that's one that one chooses. You have a spontaneous abortion, and that's essentially what we all used to call a miscarriage. You have the ectopic pregnancies, and they can be listed in there because the pregnancy did not come to fruition. There's therapeutic abortions, which people choose to have because of, situational things. They were had high blood pressure at 15 weeks and they were already preeclamptic and they had to deliver. That would be considered a therapeutic abortion. Trying to think along the rest of my numbers here. And typically the para is the number of births that you have after that 20 weeks. So you would think of living pregnancy. So if you have a set of twins that are born at 37 weeks, they may be a G1. Their para would be then a 1 because they had a term pregnancy. They didn't have any preterm, so it would be a 0. The amount of abortions they've had would be 0. But then their last number, living, could be 2 because they have 2 living children that came from that. So you kind of have to look at the whole amount of numbers that they have listed before you can kind of say, okay, what are they writing here? When you're in the hospital, they'll just say, oh, they're a G3P2. But if you're actually on a labor and delivery unit, they usually spell it out pretty extensively what they've had and what they haven't had. Is that helpful, Rick?
Yes, as you probably remember last year, your sons came and we're trying to clarify that because what we found out is depending on where you're at, what region, what hospital, everybody uses a different scoring method. I was familiar with TPAL because I worked at a hospital that did birth, had its own OBGYN unit. So the GP, TPAL, but then the book just breaks it down into GP, and then other people, oh no, you have to put the number of abortions in there. So it can become very, very, very confusing at times with individuals. But as long as you guys know that when you walk in and you hear somebody say a GP, it doesn't stand for general practitioner, gravida, para, and those actually mean something.
Right. And usually, I found between the schools that I've gone to, and then also going down to Drexel, working at York, just even getting patients that we get from other regions to where I work, they typically use we typically will see written, I guess I'll say, from the GYN standpoint, from GYN providers, those 4 numbers, the Gravida and then the TPAL. Now, if you go to a family doc, you tend to see just, Gravida 3, Para 3. That's it. They don't typically, and then you ask the patient, how many times were you pregnant? And they're like 6, and because they don't go quite as in depth as everybody else. But that is an important piece to remember, because sometimes you can stick your foot in your mouth that, this child, they actually had a deceased child and you didn't know it, or you thought they had a miscarriage and their, baby died at 22 weeks and, isn't living, but somebody just made it a G and a P and that was it. So patients will say, well, I did deliver a baby. So just knowing what region you're in, but a lot of times, if you're taking a labor patient, they'll want to know the big long number. If you're taking somebody to the ED, they'll take short numbers. All right. Any other questions on the actual material, or do you want to look at the case studies or the case study and then you make the call, the review questions?
Sure. I just have one more clarification I'd just like to point out. Ladies and gentlemen, Tiffanie had said, I can't exactly, I'm just paraphrasing, regarding doing internal exams. Please remember, under our current scope of practice, paramedics are not permitted to do any internal exams on any patient, whether it is rectal or vaginal. So just know that. Now, there is, when we talk about obstetrics and delivering babies, there is the appropriate way to relieve shoulder dystocia and putting your fingers in to the vaginal opening when it comes to taking care of a child that is stuck in a birth canal. But when we're dealing just with GYN emergencies like this, we do not pack and we don't do any digital interventions at any point in time under Pennsylvania current scope of practice. That was it.
Rick, a question. It's probably more for Wednesday's lecture, but for prolapse cords, they do or do not do any type of
yes, that's a newborn child. That was just something I forgot. But yes, when we end up having a prolapse cord or anything else like that, we are permitted to insert 2 fingers, 3 fingers in there to help lift, relieve the pressure. Exactly, relieve the pressure from the cord.
I just wanted to make sure before I made that lecture.
Yep.
to say, oh, well, you can do that, and then say, oh, no, you shouldn't do that.
Yeah, no, that is appropriate. But if we don't have a presenting limb, presenting airway, cord, or anything else like that, we're not permitted to go and do any. We're not educated, nor are we permitted to go in and check, effacement or anything when it comes to cervix dilatation or anything like that.
Hey, if it's going to come out, it'll come to you. You don't need to go to it.
There you go.
All right. So do we want to look at just the review questions so you have kind of the information with that?
If you have a case study, that would be great. If you have one over there, that would be great.
I just have the ones in the book because, I'm privy to having a book.
Oh, okay. Yeah. Why don't you go ahead and run through that? That's great.
2 books, actually. I paid for 2 sets of books for paramedic school.
Okay, good.
At the same time.
All right.
So the case study that's in here is a sexual assault case study, and then the You Make the Call is a patient. I'm trying to see here. Oh, she is a young 17-year-old patient that they're actually both pretty good. I'll start with the You Make the Call one just because that may be a little bit more relevant or more often, and not only at a college, but just in general in life, as opposed to the sexual assault, which will be obviously a good one too. So it's on page 15 in my book, if anybody has their book and wants to look at it. So late one evening in early winter, you're dispatched to a dormitory at a local university for a female patient with abdominal pain. When you arrive, the resident assistant escorts you to the room of your 17-year-old patient. There, the resident assistant introduces you to your patient and tells her that she will wait in the other room. Your patient is slightly built, young female who appears to be acutely ill. She's lying on her left side with her knees drawn up to her chest, crying quietly. Her skin is a little flushed. She's diaphoretic. She's tearful, and she says she has excruciating lower abdominal pain that has increased in intensity over the past several hours. She says that she hasn't eaten today. She was very nauseated, and she denies any vomiting or diarrhea. Her her blood pressure is 82/64. Her pulse is 116 and thready. Her respirations are 24. Her pulse ox is 95%. Her temperature is 104. Her lungs sound clear. They're equal. Her abdominal exam is diffuse pain over her lower quadrants. She denies any past medical problems. She says she takes no medicine, including any birth control pills. She denies any allergies. Her last menstrual period was 7 weeks ago. And she noticed earlier that evening that she had a foul-smelling bloody discharge. After questioning, she admits that she found out she was pregnant a week ago. Her boyfriend, she told her boyfriend, he told her to get rid of it, and 3 days ago she had an abortion at a local clinic. Her obstetric history is then a gravida 1, para 0, and obviously her abortions would be 1. If you wanted to do the TPAL, it would be 0010. So what's your first priority in taking care of this patient? Or what are we thinking is the problem here?
We got a chat right there. So
Sorry,
Brandon,
I don't know how to get that to come up.
okay, there,
Oh, there we go.
up in the right hand corner, Brandon Martin says a hemorrhage.
Okay, so you're thinking that she could be having a hemorrhage.
Is it ectopic pregnancy?
Well, she could. So we're talking about differential things that you have going on right now. So you think she could have a hemorrhage. Samuel says that she could have an infection. What are our risk factors for this patient?
Everyone, if you're able to unmute yourself, as long as you don't have a lot of background noise, instead of typing this stuff out, why don't we go ahead and get into a discussion? Just make sure all your background noise is kept to a minimum, please.
Well, I know the answer. So
is there any way that you can just put like bullet points of what her like vitals were and what exactly she was presenting with, just because it was a lot and just trying to keep track of what exactly was going on was a little difficult.
Sure, I will write it. I'm going to put it over in the little chat box just because I'm going to try to anyway. Well, it doesn't want to let me write in there. I keep getting dinged. All right. So how about if I list it out for you guys and you can kind of write it down or process it. So she's 17.
If you talk slow, Tiffany, I'll type it out and send it out.
Okay, I had it when I type in that corner, it beeps at me. So she's 17. She had a period 7 weeks ago, and she had an abortion at a local clinic a few days ago. 3, I think it said. Her blood pressure is 82/64. Her pulse is 116 and thready. Her respers are 24, and her temp is 104. She has diffuse pain across her abdomen. She had foul-smelling bloody discharge earlier that day. Your scene assessment is essentially she's lying on her left side. She has her knees up to her chest and she's crying. She does appear a little flushed and diaphoretic. And of course, she's telling you about that pain that has been for several hours. And she's a little nauseated.
The diffuse pain kind of sounds like the PID that you were mentioning, the pelvic inflammatory. She had that invasive procedure done. She's got a temp. She kind of meets the sepsis criteria with the hypertension and tachycardia.
Right. So if we think about she is at high risk, and it was one of the things that I had talked about underneath the specific examples of endometritis. So an infection of the uterine lining, which can be a complication from miscarriage, childbirth, D&C. It mimics the PID. This is something that can cause sterility, sepsis, and death. So all of those things are extremely important to look at. And of course, she has essentially the signs and symptoms that are even listed in the book: the lower abdominal pain, the bloody foul discharge. What's your first priority for this patient? I mean, obviously you have her vitals now, so what would be your next step for her, obviously?
I would say fluids.
Right, so you're gonna get an IV started and give her some fluids. I'm sorry, what was that?
Background noise, disregard that.
Oh, okay. So, yep, IV access. You're going to give her fluids, maybe some oxygen. You do also want to try and find out, who did this, where, what, are we talking? She just said had it done at a clinic. Is it an actual clinic? So getting just a little bit of information. That way you can relay that to whomever is going to be getting her, that they can get other information should they need it. We talked about the fever and infection. The other thing that you would want to check, she said she had an abortion at the local clinic. Was it an abortion pill that they gave her, and she's now going to start bleeding more, passing some products of conception, or did they do the actual D&C? So you have kind of those differentials going back and forth of some type of an infection going on in there. Is it endometritis, or is it sepsis from something else, or just what's going on there? And the other thing, did they perforate something when they were in there if she did have a D&C?
Tiffanie, can you explain the surgical concept behind a D&C?
Sure. So a D&C, so you have the dilation portion. So they have to dilate the cervix a bit to get it to open, because obviously the cervix is typically closed and clamped shut or closed. They dilate it usually with some, they're small plastic or metal dilatation pieces that they go through the cervix with, and then they take a curette, and there's all different sizes, and they're kind of sharp on the one side. They pass those also through the opening, the cervix there, and they essentially just scrape all of the lining of the uterus out, and then that is what sloughs off and comes out. Unfortunately, it doesn't always slough off, it doesn't always all come out, or they may have missed a piece in there also. So sometimes you have that. And then sometimes they'll also do a D&E if they're a little further along, because the products can be a little larger, and the dilation part is the same, but they'll actually use kind of a suction vacuum that will essentially pull it all out at the same time once they get the cervix open. And that can be elective, and that can also be, a missed AB, a therapeutic AB, any of those types of where they need to remove the products in the uterus. And also they do D&Cs for many other things for women as well, but just that's typically the abortion part of it. All right, so we've got other medical history, recent illnesses. It says she doesn't have any medical problems, so that's good. No medicines and no birth control, so that was important to know. And she did say she was sexually active. Definitely you want to know if she's on any anticoagulants. We talked about the likely cause, and then it says, because your patient is a minor, do you have any legal requirements to notify her parents or obtain consent before treating her?
No.
Right. And it's, you know, she has implied consent to do it. She needs the medical attention. So any other questions kind of about her or her scenario or what she's looking at or why she's doing certain things? She's in that typical left side, knees up, because it hurts. So if you can pull it all up together, it hurts less.
My only question is that a typical finding after an abortion? Is that very common?
No, it's not very common, but you know, it can happen. And they're the ones that go from, of course they didn't tell anybody, so they go from feeling okay to feeling crappy pretty quick.
Tiffanie, also, what can you expound on any socioeconomic issues that you may see based on individuals, based on their socioeconomic status? Are there cultures or races which have more children by a younger age? Do we see nowadays, do we see older females holding off on becoming pregnant until their later years, which ends up adding other issues? What do you see as far as a, through the span of the reproductive life of a, female in today's society? Can you comment on any of that?
Yeah, somewhat. So my current office is right beside the maternal fetal medicine office, so I tend to see a lot of that. I don't necessarily know that there's, I guess I'll say, a big change. I mean, I live in York. I work in York. We have a very lower socioeconomic and we have a very high socioeconomic group. So we have women that are, 40 and we have women that are 15. I was a teen mom. I was 17 when I got pregnant with my son, and it was a tough road to hoe. But you also have the 40-year-olds who don't have it together. Medically speaking, women now, a lot of women are a lot sicker than they used to be. And the ones that are waiting later in life, I guess I'll say, over that 35 years old or that advanced maternal age part, they tend to obviously have more concerns, not only from the genetic standpoint, but from the health standpoint. You look at risk factors in obstetrics with, African Americans tend to have more preeclampsia. The maternal morbidity and mortality is horrible for African American women. Even in the US, that's the highest number of women that die during childbirth or pregnancy is African American women. And how do we stop that? So that's one of the biggest things. We also tend to talk a lot about, we always say that the NICU babies that are now having more babies. So you have these babies that were born and survived at 25 weeks with lots of respiratory problems and things like that, who are now 20 years old and having a baby. So they have underlying known problems, and then add in there a pregnancy, which causes a lot of, as we know, changes with the lungs and the heart and the capacity and the blood volume, and gives them a whole nother ball game of risk factors and problems that can occur. So it tends to go a little bit of both ways. You'll see patients who are happily married at 25, and by the time they're 35, they have 5 children, and it's just kind of how they wanted. And then You have the people that are, 40 going to reproductive endocrinology using a sperm donor to have the one and only child that they want, and they don't need a partner to do it. So our area, and I think lung cancer is somewhat the same, is that we tend to see kind of both ends of the spectrum on all of that, and we all take care of the high risk patients, so you'll tend to see a lot of that as well.
Okay, thank you.
Mm-hmm. All right, so I think the only other part there is there are some review questions. I should have put them all on slides, and then you could have dinged your answer. So the female external genitalia are collectively known as the labia, the vulva, the mons pubis, or the perineum are your review questions. You can shout it out. Nobody's shouting it out. So the female external genitalia are collectively known as the vulva. Can anybody tell me the names for the two folds of fatty tissue that arise from the mons pubis and extend to the perineum? Correct. Would it be the majora or the minora, Brandon?
Go ahead and type it out, Brandon. You said you were having a mic issue.
That's fine. Correct. So the larger outside are the majora, and then the little smaller ones on the inside are the minora. So the membrane that forms the outermost layer of the uterine wall is called what? And we didn't go over all of this, so I'll tell you the answer. So the outside lining is the parametrium. So outside, think of a perimeter that goes around the outside. The middle of the uterine muscle is the myometrium, so the muscle, myo. And then the endometrium is the internal portion. That's the side the part that sheds every month. So you have the parametrium, the myometrium, and then the endometrium. Typically, regardless of the length of the menstrual cycle, the time from ovulation to menstruation is typically how many days? Correct. Brandon, you're doing a great job tonight. So the good news is there's only 4 more. What term is used to describe the number of times a woman has been pregnant? Para, parity, gravida, or abortion. The number of times they have been pregnant. Yep, gravida. Abdominal pain associated with ovulation is called dysuria, endometritis, Mittelschmerz, or endometriosis. All right. Yep, that's right, Mittelschmerz. So middle means it's M-I-T-T-E-O when you spell it, but middle of the cycle, that's when your pain is, and that's when ovulation is. So The most common cause of non-traumatic vaginal bleeding. So PID, labor, cancer, or spontaneous abortion. So remember, spontaneous abortion is a miscarriage, a pregnancy loss. Correct. It's the spontaneous abortion or pregnancy loss. Yep. And then the last one, it says, in the case of sexual assault, the paramedic should determine whether any life-threatening physical injury exists, respect the patient's wishes whenever possible, and offer emotional support, make every effort to preserve physical evidence, or do all of the above. I was gonna say, that's an easy one, all of the above. All right, is there anything else? We went over you make the call, we went over the review questions. I'm happy to answer any questions you have. GYN is not my favorite. I'm an OB girl at heart, but all right. Well, Rick, do you have anything else for them that you need?
Nope. I will be, as soon as we're done here, I'll be rendering this and I'll try to get it up into the file folder that I shared with you guys earlier. That way you can review anything else like that. Well, this will be the same way we'll be running Wednesday night's class. So we'll start again at 6 o'clock. I hope to get some more videos up for you, some voice narrated stuff, get some case studies and start working on some oral stations, as well as please keep an eye out. I had accidentally left all of your quizzes that I had here at the office. Now that I'm back, I'll be able to put those in as far as scores and everything. And I just continue to work on the online stuff in your flat student project as we move forward. And as I said, I'll be getting you more information as available to you as soon as I can get it. If nobody has any questions, I'd like to thank Tiffanie for her time this evening. And if nobody has anything, see you guys all Wednesday evening, 1800 hours. Same computer.
Thank you, Tiffanie.
You're welcome.
Thank you, Tiffanie.
Yeah, you're welcome, Rick. I'll get the OB stuff together. Is there certain types of case studies that you need?
It just again, if you could have something regarding like when we start talking about obstetrics, talking about somebody who's preeclamptic goes early, your if you could talk about the difference between, and I don't know if it's an old dogmatic idea as far as grab the one pair of zero where they're in labor for the first time and it takes forever, whereas if you've got somebody who's grabbed a five pair of four and they come out quicker or something like that. Talk about that.
I could just use mine.
There you go.
My last one was born out while I was working.
There you go. Talking about abnormal presentation. I unfortunately I took an also class last year because OBGYN, again, me being a male, honestly, I never saw a live birth until my son was born, and he's 21 now. Even going through my education, unfortunately, there is a large gender inequality when it comes to the clinical education of paramedics. Your son's experienced it,
right?
Going over to women's and babies and stuff like that. So,
kind of. Ryan got to see and help with the delivery because my friend was the nurse manager there. So I was like, look for him.
But it's one of those things that we constantly struggle with. It depends on,
I know when I was, when we had students, it was tough.
Yeah. But anything like that, with from breech to limb to
Mhm.
cord, anything else like that. Talk about the equipment. And the fact of the matter is, one of the things that most people do, especially and for those that are still sitting in there, Sam, Sean, and Brandon, especially our male providers, we tend to freak out when it comes to um, obstetrical emergencies. Um, good, bad, or indifferent. Most guys would, want a nice, massive trauma. Whereas if we get a woman in labor, everything's, dogs and cats living together, that stuff. So yeah, I did normally, if we were in class, I do have a video where a friend of mine who's a life flight nurse who started out in OBGYN got me a copy of Assisting a Vaginal Breech Birth. I wish I had the ability to take it over. It's in VHS. I've never got it rendered over, but talk about some of the issues. I mean, as well as the one thing you could talk about is multiple births. If someone is pregnant with twins,
Mhm.
how that can very, very quickly become a mass casualty incident. You get two children plus mom. We always have to worry about mom
Mhm.
too. So just stuff like that.
Oh yeah, well, I've high risk OB for 14 years, so
There you go.
you
Okay.
know, you should really talk to Ryan. He did 3 vaginal deliveries, one in the back of a Toyota truck, and I think 1 or 2 in the ambulance, like
Mm-hmm.
in like 3 weeks.
Mm, yeah.
Like none, and then 3 weeks he did 3 of them.
There's a magnet there.
I know. He hasn't had any since then, I don't
Uh,
think.
that's enough for a career.
Yeah. All right. I didn't know if you needed specific case studies when you were saying to the students, like putting them online, because I have access to all of Drexel's.
That would be wonderful. If you could get me something I
So,
could read through them and yeah, we could share. That would be great.
we have those, and I actually just got my email tonight that they're going to actually do some SP type. They have patient actors, and they're going to do cases and like have them recorded so that they can watch them.
Oh, that'd be great.
I'll have to ask her about that, and maybe that's something that we can share once she does that or something.
Yeah, that'd be great. I mean, because if we were in class, we have the birthing mannequin and everything else like that, as well as just the low fidelity mannequins that we're able to just put a nuchal cord around and stuff like that. But and again, as I was explaining earlier, the big thing is until the COVID issues gone, they're definitely not going into OB or
Yep.
neonate or anything else like that, which is horrible because again, those are those high risk, low frequency patients that we're very rarely going to see, but expect to be perfect on
Proficient.
everyone. Yeah.
Yep.
Yep.
I
So,
understand. I totally get it.
yep. So, all righty. Well, unless you need
All right. Well,
anything from me,
thanks.
I will see you or talk to you on Wednesday evening.
All right. Thanks.
No problem.